It's fantastic to be here. And I'm going to start by saying that if I had a magic wand that would enable each of you to remember just 2 words of what I'm about to say, then it would be these 2 words, only connect. The words come from a novel that was written about 100 years ago by an English novelist, E.M. Forster, and the novel is called Howard's End. And what E.M. Forster was doing through this work and through lots of his wider work was partly about exploring what happens at periods of great technological change. That at those times, we often also feel pressures on our sense of connection to one another. There's often feelings of social atomization and disconnection. And his argument really was that it was very simple. What we need to do is harness the very best of our technological progress, but do so in a way that also enables authentic human connection. So the full quote is this: only connect the prose and the passion. And that, to my mind, is a challenge that really is at the heart of health. So we need all of the fantastic biomedical breakthroughs, the clinical insights, the ways in which we are saving lives now in ways that were unimaginable just a few years ago. But we also need to remember that we are all humans, that we need social connections. We need a sense of being heard, being understood, being supported, accepted, valued, and to have a sense of hope. And we've been exploring these issues through work that we call people-powered health, and it's that body of work that I'm going to share a little bit with you this morning. And the best way, I think, of bringing it to life is through the experiences of the people that we've been working with. So one man in particular, Alex, he lives in a place called Salford in Greater Manchester. Now, by coincidence, Salford is also the birthplace of the great William Worrell Mayo, the founder of the Mayo Clinic. And Salford these days is an area of significant deprivation, poverty, and all of the challenges associated with those issues. Alex himself is in his 30s, but as a child he experienced years of abuse. And as an adult, he was finding it difficult to find his way through. He had 3 kids of his own, but he'd got to the point where he couldn't even take his own kids to the park because the park felt too public. There were too many other people there. He was uncomfortable. And so his horizons were narrowing. And that was despite the fact that actually he was being seen by a whole bunch of different health professionals. He was on medication. He was being referred around the system. But none of that was making a difference to him. He had, in effect, stalled. It was as if his confidence and his purpose and his hope was like a pile of dust at his feet. And what made the difference to Alex was something very different. It was actually a chance encounter that led to him joining a fathers group, a group that had been set up to connect fathers to one another, to share stories and to support one another. And with the support of that group, Alex gradually built up the confidence to begin to share some of the very painful experiences that he'd had. And the moment that changed things for Alex was the moment that he realized that other fathers in this group had experienced similar things, that they understood what he was going through and how he felt. And that was the turning point, because it was the moment that he felt accepted and that he felt supported by other people. And it was the moment that he began his path to recovery. And by the time I met him, he was not only hanging out in the park with his kids, he was supporting other fathers on their own paths to recovery. And he joined us in London and shared his story in front of 400 people, including the incredible news that the day before, he had started a job for the first time in 18 years. Now, that's quite an incredible journey to make, from barely being able to leave your own house to standing in front of 400 people. It was also quite a journey for the staff that were supporting him in that group. So the group's called Salford Dads, and it's set up by a fantastic organisation called Unlimited Potential, a community-based organisation. And one member of staff in particular is a nurse called Heather. Now, Heather had trained originally as a traditional nurse, but she had got to the point in her own nursing practice where she felt that she was, in effect, putting a sticking plaster on issues that ran much, much deeper. In effect, the social determinants of health. And she took a big step herself to retrain in various different techniques, including community development techniques that are all about equipping people with the confidence and the skills to connect to one another and to solve problems. And in her own brilliant words, she says, "The only thing I inject these days is confidence." And that, to my mind, is what really sums up the work that we've been doing on people-powered health. But before I tell you any more examples of that work, let me just tell you one or two things about me and my perspective. So perhaps the first thing to say about me is that you've probably already realized that I'm not American. And as a Brit here, I'm very aware of the differences between our healthcare systems. So in structural terms, if you were to put us on a spectrum, we'd be at opposite ends. But I think we also share some common challenges. And I think the first is that despite the differences in the way in which our healthcare systems are structured, there's an increasing consensus in both countries that their current configuration is financially unsustainable. We also, I think, share a bit of a failure, I would argue, about making the case for preventative and upstream investment. And I think, thirdly, we share a common challenge, a common strategic challenge, that we need to stay just as brilliant at acute and infectious disease, but get much, much better at supporting people with ongoing and chronic conditions. And it's people with chronic conditions that has been the focus of the work that I've been doing. So that's the first thing about me, that I'm not American. The second thing about me is that I'm not a clinician. I think probably the best way of describing me is as a kind of lapsed or ex-policymaker. So I spent a lot of time in government making policy at both the local level and the central level. So I've worked in number 10 Downing Street, supporting the Prime Minister on a lot of different policy issues. But it got to the point in my policy career where I felt that the highly analytical policy-making process was so incredibly isolated from some of the really important realities of what we needed to be taking into account. So it was isolated from the delivery and the implementation of the policies. It was also completely isolated from the citizen perspective about what do people actually want and what do they need. So I got to the point of wanting to look for other ways of achieving change, other tools to be using. And so I took the decision to leave government and I joined an organization called Nesta, which is an innovation foundation. We're a charity, and we're all about innovation for the public good. And we do that in a number of different ways, which is one of the reasons why it's such a fun place to work. So we engage in research. We're also an innovation grant funder, so we fund new practice on the ground. And we're an impact investor, so we invest for social impact. And a lot of our work is about supporting people to feel empowered, connected to one another, in ways that means that they're more in control of their own lives and also have a sense that the future is there to be shaped. The future doesn't just happen to us. It is within our grasp. It's within our potential to change the future. So we are a fundamentally optimistic organization, but we ground that optimism in the insight that we get from the front line, from frontline service deliverers, and also from citizens. And we use those insights to come up with new solutions to problems that we test in practice on the ground. We test and we iterate until they seem like they're working, and then we develop evidence of impact to show what works. And we use that grounded insight then to influence policy and practice. So that, if you like, is our theory of change. And so, as I said, we've been developing a whole sort of body of work on people-powered health. And I think the best way of bringing that to life is, as I said, through the stories of the people that we've been working with. So a second example is a man called Harry, in his late 60s. He is living with chronic lung disease. As a young man, he had been a competitive swimmer, but that felt like a long, long time ago. He got to the point with his chronic lung disease where his levels of breathlessness were making very everyday tasks very challenging indeed. He was getting very good clinical care. The doctors were trying to encourage him to take some small steps to be more physically active, but he was absolutely terrified. He couldn't believe that he would be able to survive taking those steps to be more active. And so what changed things for Harry was being connected to a local peer support group of people with chronic lung disease. And through that, he realized that there were other people who felt the same way as him. He had a sense of hope, a sense of belief that things could get better for him. And with the support of those people, he began to take steps. It was a long process. But by the time I came across him, he was not only the life and soul of the peer support group, he was swimming several lengths of the swimming pool every week. It was really quite remarkable, the journey that he'd been on. And he puts it down to that feeling of hope and support that he got from those other people. And we've been supporting the organisation that runs those peer support groups, which is called the British Lung Foundation. It's a patient charity. We've been supporting them to generate evidence of impact. Do these peer support groups actually work, or do they just, is it sort of marginal? They now have control group level data that shows that these peer support groups reduce unplanned primary care visits and unplanned secondary care visits. So they work. These connections are making people better. So that's an example, if you like, of relationships and connections between small groups of people. But we're also interested in what does it look like when you really begin to scale that up? What does it look like when you make connections between people who are mobilized and connected through a shared passion to make change? And so we're also very interested in social movements for health and the power of social movements to make change. And one person that we've come across that actually is connected to Genetic Alliance, which, if you haven't heard of it, is an absolutely fantastic, it's a US-based patient advocacy and research organization. And she summed it up like this: being part of a social movement is that sometimes you are so exhausted by the problem, you will dedicate everything to the solution. And I think we've heard this time and time again on this stage over the past few days, the power of when people want to come together and affect change. And I saw this firsthand, actually, when I was back in Whitehall, when I was a policymaker, seeing the extent to which the disability movement in the UK has made a difference to health policy there. So one of the most radical changes, I think, to British healthcare policy over the past 10 to 15 years has been the introduction of something called the personal health budget. And that means that instead of getting public services, you're given cash. It's hugely challenging for the system to accept. It's really difficult to get this, for the system to get their heads around it. It feels very, very radical. But it came from disabled people wanting more control over their own lives, that they were sick of being shunted into stigmatized and segregated public services. They wanted to be able to choose how it was that they could live their lives in ways that made sense for them. And so this amazingly radical policy change has come about through that external pressure of disabled people calling for change. And it's a real reminder that it takes a long time and it's extremely difficult, but change can happen. So as I sort of reflect on this work that we've been doing with citizens in people-powered health, there are a couple of reflections that I wanted to share with you, really. And they're reflections that I think challenge some of the dominant ways in which health and healthcare are sometimes understood. So the first reflection is that our work starts from right outside of the formal health and care system. It starts with people in their everyday lives, and the knowledge and the skills and the confidence and the support networks that they need to live as well as they possibly can with ongoing health conditions. And that's not at all to say that improving patient experience in clinical settings isn't important. It absolutely is. But we need to go way beyond that. We need to be thinking about how we equip people in all of the time that they're not near a clinician to live the best lives that they possibly can. So we need to start from the perspective of the person, the whole person, the citizen. I think the second reflection in terms of our work is also challenging the idea that a professional is always the answer. I think sometimes in health we have a tendency to over-professionalize things sometimes, in the same way that I think we have a tendency to over-treat. So there's amazing work that we're involved with, that we're very supportive of. It's absolutely essential. Work to support the workforce to be more enabling and facilitative, to have great conversations with patients in clinical settings. And there's an amazing differentiation of roles, things like nurse coaches, multidisciplinary teams that are really forging very, very important new work in terms of how you can support people within clinical settings. But I think the experience of Alex and Harry show us something else. They show us that sometimes, perhaps, you can't substitute for shared lived experience, for that authentic human connection to someone who genuinely understands what you're going through. And I think we should hold on to that as well. So over time, we've been developing this work with citizens from the citizen perspective. And over a period of years, it became very, very clear to us that actually everything that we were finding with citizens and their relationship to health absolutely applied to the people working in the health system too, to healthcare professionals, to managers, to clinicians. So just as in the same way that people can feel overwhelmed and disconnected and disempowered by their own health, so too can professionals feel burnt out. They can feel disconnected from the purpose that brought them into health in the first place. They can feel completely demotivated and feel like they have no agency, no way of making things better and to solve all of the problems that are right in front of their eyes. And so what we did was to try and take some of the learning that we developed with citizens and apply it to professionals. And we did that with an organization called the Rapid Results Institute, which is a US-based nonprofit. And together we developed a 100-day innovation method that is really all about galvanizing a local health system to commit to change and to try and achieve that change rapidly over the period of 100 days. And again, I think the best way of bringing it to life and explaining it is through the experience of the people that we've worked with. So I think back to a healthcare leader that we worked with in the early days, and let's call him Paul. I remember very clearly our first meeting with Paul. He was a senior guy. He was responsible for a huge section of the local health economy. And we'd managed to get some time with him, and really all we wanted to do was just explore whether or not he wanted to give this 100-day challenge a go or not, whether he'd be interested. And the meeting was in an incredibly dingy basement office in a civic hall. And we were explaining about the method and the potential for innovation and transformation. And it was very clear that he was, to be honest, he was barely focusing on what we were saying. He was staring down at his papers. He wasn't making a great deal of eye contact. It was very clear to us that he was completely overwhelmed with the pressures that he was under, the pressures that his staff were under, the financial crises, the workforce crises. And so when we left that meeting, we thought, well, who knows, but maybe we won't ever hear from him again. So we were surprised and delighted to get the call 2 days later, and he said, do you know what, let's just give it a go. And I think it was because he'd come to the end of his own road. I mean, he didn't really know what to do next. He was facing so many pressures from so many different directions. And so what we did then was we took Paul and we drew in other leaders from across the health system, from all different parts of the health system, different providers, different parts, and we got them together and we asked them whether they would like to work together on a challenge that they wanted to make some progress on. And they said yes. They're barely ever in the same room as one another. They said yes. And the issue that they chose was frailty. So they wanted to reduce the number of times that frail older people were admitted to hospital unnecessarily. That was the challenge that they wanted to work on together. So once we got them together as a leadership group and we had their permission to do this work, we then gathered teams at the front line, and each team represented the whole system. So there was primary care, secondary care, mental health, even the voluntary sector was at the table, and patients, people with lived experience. And those teams were charged with 100 days of action. They were given the permission to try things out. So it was 100 days of action rather than 100 days of planning. And they came up with fantastic things. They trialled a new frailty register. They trialled a new flagging system so that when somebody arrived at A&E, the emergency department, they could be flagged as being frail and they could be treated differently. They trialled a patient-held record so that we could record people's care preferences and act upon them. But just as important as all of those solutions, many of which were scaled up and adopted afterwards, just as important as all of those things was the passion that was unleashed when people were involved in the change, they were invited in to be part of the change, they owned the change, they were part of it. And to my mind, that sums up really this quote about the need to combine the best of the technological, the process, the clinical, the best of that. Take that and combine it with the best of us as humans in terms of our motivations and our support and our connections. And that's the way through to a transformation of health. And I think the reason why the method works is it actually is very, very simple. It understands that change is not just a technical process. Change is also a social process. We need to feel part of it. And I think that's the very simple insight, and that's the reason why it works. So I hope I've shown that through the work that we've done, one of our biggest sort of learning points, if you like, is the need to combine the prose with the passion. And when you do that, I think incredible things can happen. You get Alex back in the park playing with his kids. You get Harry swimming lengths of the swimming pool. And you get Paul leading complex change under a great deal of pressure. So, as I said at the beginning, if there's only a couple of words that you remember from all of that, then I hope it's these two. Only connect. Thank you.